training is a critical aspect of the Government of Alberta's FASD 10-year strategic plan. And this is addressed through various initiatives throughout the province, such as video conferencing learning series. We're very pleased with the ongoing interest and attendance in this initiative. Now I have the pleasure of introducing Dr. Shanif. Dr. Shanif Esmail is the Associate Chair, Associate Professor, Department of Occupational Therapy at the University of Alberta. Dr. Esmail is the occupational therapist with clinical and research interest, focusing primarily on sexuality and disability. Specific areas of interest in research include sexuality counseling and intervention for couples impacted by disability or illness, and sexuality training and education for children with disabilities and their parents. Dr. Esmail is also professor for the physical assessment courses in the Department for Occupational Therapy, as well as a variety of human sexuality courses at the U of A in the faculties of Rehabilitation Medicine, Medicine, and Human Ecology. Please join me in welcoming Dr. Shanif Esmail.
Well, thank you for that wonderful introduction. I'm just, first off, happy to see that we have some people in the live audience. I've done teleconferences where, let's just say I've been the talking head to an empty audience, and there have been lots on-site but not live. Please ask lots of questions. Although it looks like we have a lot in terms of the handout, it's quite thick. You'll notice that the last about 8 pages are references. So don't worry, we will get through it all. My goal today is to bring about some awareness on the impact FASD has on sexuality and sexual functioning. Also, we're going to look at it not only for children, but generally throughout the lifespan. So I'm going to also touch on adult issues as well as childhood issues and the whole spectrum. So please ask lots of questions. My goal today is to give you some information, the significance, and then we'll move on into, I'm hearing an echo, but that's okay. And then we'll move into sort of some of the barriers that individuals with FASD face, and that could be personal, institutional, or attitudinal. And then we'll get into some specific strategies on sex education and what you should do. All right? There's no answers to this problem. The problem is there's not enough research done in this area, and we need to do more research. But what I have done is amalgamated some literature on the topic of FASD and sexuality. But I also looked at related literature in terms of impact of mental illness on sexuality, impact on just disability in general, specifically looking at developmental, dual diagnosis, and all the whole range. So you'll notice that the literature review that I've done in the back, or the list of literature, has a wide range of literature in there. So please have a look at it. You will find it quite valuable. So to begin with, we have to talk about what sexuality is. And we always think about sexuality as the physical aspect of having sex. Please, that's a myth, and it's not something we want to do. So what we want to do is look at sexuality as the whole person. It includes everything that we do, our sexual thoughts, experiences, what we learn, how we relate to each other, our ideas, our images. And sexuality, according to this diagram, you'll notice, is not just physical expression. Physical expression is right at the bottom, one corner of the whole picture. I put values and beliefs up at the top because, especially for FASD, you'll find that values and belief systems play a huge role in how sexuality is expressed. And when I say values and beliefs, yes, for the individual, but also for the parents, the healthcare providers, the service providers, the educators, all of their values and beliefs will impact sexual expression. Then we talk about body image, self-esteem, communication, personality, gender, socialization. All of these issues will be impacted by FASD. All right? So, another thing I wanted to just quickly, because I'm setting the stage around sexual health, the World Health Organization has worked hard to bring sexual health to the forefront in terms of a very important issue in terms of quality of life. And I really like their definition. It talks about a state of well-being related to the physical, social, emotional, and mental health of a person. Notice they don't talk about just the negatives. It's not just the absence of disease. It's also the positive aspects. And the World Health Organization is trying to get the message across that for quality of life throughout the world, sexual health must be addressed. So they talk about how sexual health requires a healthy, positive, respectful approach. Okay. Also, the possibility of having pleasurable and safe sexual experience free of coercion is really part of our innate needs. So we need to look at sexuality from a positive aspect, not just from a, oh, we got to stop it, prevent it, and all of that. Now let's talk about some basic assumptions, all right, before we get into all of that. When we talk about basic assumptions, we're talking about basic assumptions we need to keep in our mind as we're thinking about this topic and working with individuals with FASD or any disability. So generally when we talk about it, all persons, regardless of disability, are sexual beings. So we have to look at them and treat them as sexual beings. A person has a right to all information about sexuality that he or she can understand, at a level that he or she can understand. Also, they should have a right to a full range of sexual expressions, just like you and me. So we shouldn't say, oh no, you have a disability, you shouldn't be doing that, and we prevent them from doing it. And we'll talk about some of those issues later on. Also, the person with the disability has a right to develop relationships with others as well as for themselves, express affection and sexuality in what way they deem is comfortable for them, as long as it's non-coercive and not have some sort of person that's being victimized. So now let's get into specifically FASD. Initially, I had about 8 slides talking about the impact of FASD in terms of brain function and all that. And I was informed that there have been several sessions, and what we've done is listed some of the sessions where you can get the background information on the impact of FASD on brain functioning. So I'm not going to go through that and bore you with that. But please review it, because you will see, and what I have done is gone through and talked about implications of FASD on brain functioning, just as it relates to sexuality. All right? So I've sort of narrated down, and I'm not going to go through the whole thing, but you do have the resources there. Now let's look at brain functioning. Individuals with FASD tend to exhibit socially inappropriate behaviors. Okay? And at times, they have trouble sort of making decisions or coming up with solutions spontaneously. If you're in a sexual situation, for example, and someone approaches you with an inappropriate comment or something like that, you'll react to it and you'll deal with it appropriately. Someone with FASD may not do that. Or if they're propositioned for certain activities, you might say, oh no, that's not right, or say, hey, come on for a ride with me. Right away you're thinking, what are the consequences of this? And you'll stop yourself. Someone with FASD may not. They'll react and they'll say, okay, I'll come along, and they won't think about the consequences, they won't think about protecting themselves, so there's those kinds of issues. Also, inability to control sexual impulses. This is an important one because we all have sexual urges, and individuals with FASD are just like us. We have hormones that surge and all that, and we have sexual drives, and they have sexual drives too. The problem is, we know when to say, nope, that's not appropriate to do, and we stop ourselves. While individuals with FASD might have a sexual impulse, and they'll act on it. Even though they might say, oh, that's wrong, and I've been told that's wrong, but I'm going to do it anyway. All right? So there are differences. And I already talked about inability to apply consequences from past actions. The last time I did this, I got into trouble. Oh, well, I'm going to do it again. All right? Difficulty with abstract concepts or time and money. Now, how does that relate to sexuality? Well, think about it. We can talk about sexuality. A lot of sexual talk is abstract. All right? We don't talk about intercourse. We talk about making love. We don't talk about specific activity. We talk about in generalization, especially when it comes to sexuality. Communication around sexuality tends to be one of the most difficult and complex ways we communicate, because we have all these innuendo and underlying messages when we talk about sex. I mean, when you're flirting or interacting with somebody of the opposite sex or same sex, someone that you're attracted to, you don't come out and say, hey, I'm turned on with you and da-da-da-da. You use subtle images and messages. Those are all abstract concepts. someone with FASD would have difficulty with these types of concepts. So they would come up and say, I'm turned on with you, let's go out, let's have sex. And that get a very negative reaction because it's socially inappropriate. Difficulty processing information. Remember how I talked about sexuality, such a complex communication issue? Well, the part of what makes it complex is the type of information you're processing. It's at a whole bunch of different levels. You have the verbal, actual what is said, the implied meaning, the nonverbals that go along with it, and all that kind of thing. So you're putting it all together. That all needs to be processed into something that's meaningful for us. Someone with FASD would have trouble doing that. All right? Storing and retrieving information. We are a collection of experiences. How did you learn about sex? I'm not going to ask you, okay? But, we all learned about sex from various ways. We learned formal and informal. We looked at TV, magazines, what our friends told us, things we experienced ourselves. We've added it all together, and we get to some sort of combination into some sort of sexual identity. And that in itself gives us our experiences on how to react to sexual situations. Someone with FASD has trouble retrieving a lot of that information when they need it. So they're not going to be able to use it. So even when you educate and give them skills, they might not bring out those skills when they really need them. That's what makes this population so difficult when dealing with safety issues. Need frequent cues requires policing by others. And we're going to talk about just that. And I'm hoping we can get into a bit of a discussion around that. Need to talk to self out loud, needs feedback. Again, these can be can cause quite a lot of impairment when it comes to sexual functioning. Other things that you'll find with individuals who have exposure to alcohol in terms of brain functioning, you have fine motor skills are more affected than gross motor. They tend to be moody on roller coaster sort of thing. So what you're going to see is a lot of high emotion, low emotion, anger, frustration, all these things coming out at unexpected times. Also, sexual urges and impulses come out in exaggerated manner. So when they're turned on, they are turned on, and they're going to show you that, excitement, where some of us would sort of maybe hide it, right? So you're going to see all of that. Apparent lack of remorse need external motivators. So when they do something wrong, a lot of times we do things and we might say things that might hurt somebody in a sexual situation, and we're sorry, we apologize, etc., but these individuals don't. So it affects the relationship if they have established any. Inability to weigh pros and cons when making decisions. What's right, what's wrong. So all of these can affect sexual decision making. So let's move on and talk about specifically individuals with FASD and what are some critical issues that they face. And then we'll talk about FASD and sexual statistics, inappropriate sexual behavior, how there is a cycle, and what are predictors of inappropriate sexual behavior. How can we stop it? All right, so that's the next section. Okay, like I said, children growing up with FASD grow up with normal hormonal surges, and it's just part of development. The problem is their cognitive processing does not match their hormonal changes. So suddenly you have somebody who might be functioning at a lower level, has the hormones raging of an adult or a mature teenager, and it doesn't match up. So they don't know how to control these hormones. Their social development may not match their biological. Damage with the brain, of course, interferes with judgment, impulse control, and other cognitive processes. So let's get into it. In addition, many don't receive adequate sexual education. I talked about how we all learned about sex education from different perspectives. These individuals aren't getting the same amount of sex education. And a lot of times it's because it's avoided. Parents don't talk to them about sex because if I talk to them, it's going to cause them to act out. It's going to cause them to do inappropriate stuff. So it's better not to open a can of worms, right? So it's better. So they're not getting much information. The problem is if you don't give them information, automatically they become at a high risk for becoming victims or perpetrators, or both, for inappropriate sexual behaviors. So what is the mean age? The mean age is 9.6 years when you start seeing inappropriate sexual behaviors. At this young age, what you're going to see is children doing things like exposing themselves to get a reaction from their parents. Children actually, even at a younger age, modeling or mimicking sexual activities that they have seen on TV or that they've seen their parents or friends or whoever, older siblings, etc. So they're going to start mimicking behaviors. So you might see them actually simulating sexual intercourse because they saw it somewhere or whatever. So even at a very young age, they are going to do things where an able-bodied child would probably self-limit and not do this. 39% of children demonstrate inappropriate sexual behavior. It goes up to 49% for adults and adolescents who have repeated problems with displaying sexually inappropriate behavior. But generally, the statistics say 50% have inappropriate sexual behavior on a repeated thing. So it's not just a one-time thing. It's an ongoing issue. And look at this. 77% of individuals with FASD have experienced some form of physical or sexual abuse. And you'll see later on when I talk about it, having experienced sexual abuse automatically is almost like it's a high correlation between that and actually inappropriate sexual behavior, actually doing inappropriate sexual behavior. So now what is inappropriate sexual behavior? I've been sort of mentioning that word, ISB, but basically what we're talking about is inappropriate as determined by society. So what we in the general population say, ooh, that's not appropriate, it shouldn't be done in public sort of thing. So things like boundaries, making inappropriate sexual advances. Inappropriate touching. There was a case of a man on a subway in Toronto, and he was from a group home. And basically what happened was it was a hot summer day he was sitting in the subway in Toronto, and he was taught that you never touch a woman here, here, or here. And that's it. That was his training. You don't touch women there. And he was sitting there, and a woman sat beside him. And this woman was wearing a short skirt. So he looked over and said, oh, and he touched her lap. She, of course, screamed. A few men grabbed him, threw him to the ground. They arrested him. And what happened was the group home worker came and said, what did you do? Why'd you do that? He goes, but I didn't touch her here, here, or here. So all he was told was, don't do that. So inappropriate touching and sexual touching, at times they don't realize it's inappropriate because of the education they've had or lack of. Promiscuous sexual behavior. Now this, a lot of times, is reinforced because a lot of times individuals with FASD are not they're sort of almost social outcasts. And when, especially females who tend to be a little more promiscuous, become a little more popular. They get a lot more positive feedback. So guess what? They are going to act out. They are going to be a little more promiscuous because suddenly they are liked. They're popular. They're getting attention. But there's only attention for one thing. Exposing behavior. That sort of takes promiscuous behavior and goes to the higher level of getting attention. Exposing behavior tends to be more children, and it could be adults, but tends to be more children. Compulsive sexual behavior. Now, whether that's masturbation, getting into sexual situations and having sex frequently, as often as they can possibly do it, sort of thing, all of those kinds of things, where it's a compulsion to meet an unidentified need. So it's almost, the best way of describing is the sexual activity or the pleasure they derive from it is unimportant. It's almost the compulsion of doing it, and it's an unconscious need to meet certain innate needs, and they're not sure what. And it's just, I need to do this, I need to do that. So as soon as they've had sex, it's like, okay, now I need my next fix. It's almost like a drug addict in terms of compulsion. Making obscene phone calls. Again, this is more in terms of getting attention, acting out on curiosities, those kinds of things. Voyeuristic behaviors, because they're curious. They see that people, what's this about sex? So they're going to try to do this. Masturbating in public, whether it's conscious or unconscious. Sometimes they think, they don't know better, they don't have any self-control. No. Sometimes masturbating in public is a way of getting attention or making a scene. All right? Incest behavior, sometimes in relationships, usually it's with younger siblings, because again, they might be acting out or modeling certain behaviors. Unusual or worrisome sexual behaviors, deviant behaviors, and paraphilic behaviors. They've done studies with people with paraphilias, and they found that there's definitely an organic component to paraphilias, and they find that individuals with some sort of brain damage or hormone deficits or things like that tend to have a high rate of paraphilias, and FASD is no different. Okay, so you are going to see a lot of individuals with FASD who will have paraphilic behaviors, which makes things even more interesting. So I've got here, yes, Billy, masturbation is normal, but not during dinner. And I put this slide up just to make a point, because sometimes their behaviors may be perfectly appropriate, but depends on the context. They might be, just showing them that, okay, if you want to do that in your room, in private, etc. Okay? Now, inappropriate sexual behaviors occurs throughout the lifespan. But look at this, 39% in children, 48% in adolescents, and 52% in adults. Why is there an increase? The biggest reason there's an increase in inappropriate sexual behaviors is because adults don't have as much supervision. One of the things you find with FASD is if they've got the supervision, they've got the cueing, they've got the structure, you're less likely. Because, there is some control. They do. If there is a stimuli saying don't do it, they're not going to do it there if there's someone telling them not to do it. But when they become adults, they're less supervised, so they have more opportunity to act out. However, that's only part of the story. Also, as hormone levels start to peak, you're going to get more acting out in behaviors. So there is a correlation between hormones as well as supervision. So those are the two characteristics that show why adults tend to have more inappropriate sexual behaviors than children. Among children, the most frequently mentioned inappropriate sexual behaviors are exposing, as I mentioned already, and inappropriate sexual touching. Okay? Because that's basically their opportunity. As they become adolescents and adults, then you have promiscuity and inappropriate sexual advances. So now it's with other people, right? It's actually, they are in, I don't want to call it relationship situations, but in social situations where they are interacting and they are trying to have sexual activities or behaviors with others. See, when they're children, it's within a social situation, but more it's for themselves as opposed to with somebody else. Inappropriate sexual behavior for males and females. First off, you'll find that the rates of inappropriate sexual behaviors for men and women are the same. This is with FASD. Okay? However, men at times take more, get more media play because their behaviors tend to be more aggressive and they tend to be more coercive and non-consensual. While women, their behaviors tend to be more in the line of around promiscuity. All right? So therefore, men tend to get more of the attention because it's more threatening and seen as more illegal behavior. Females are more likely to be victims of sexual abuse, while males are more likely to be perpetrators. And these are individuals with FASD. So you have a higher rate of women who are sexually assaulted or abused who have FASD. But there's a thing here. There's almost this feeling by women who have FASD that they're already broken. There's something wrong with their brain. So it's okay for me to be in these situations. It's okay for me to be put in these situations. It's okay for me to be victimized. And the reaction to being victimized at times, you'd be surprised to say, well, you should be more upset about this. But there's almost this fatalistic view, well, I'm already broken, let it happen to me. And we need to change this attitude. I've got here a father of a child with FASD. I'm worried about my oldest daughter, not in the sense that she'll be acting out, but that she'll be very easily persuaded herself. She's now 12, very attractive and physically mature, although socially and emotionally very immature, and going to high school in the fall. She is a target. And the father knows it because suddenly high school is a whole different kettle of worms, you might say. And basically what's going to happen is now she's entering a very sexual situation where you have boys who see her as, hey, possibly an easy target for sexual activity. And she might be easily manipulated. So that's why the father has a legitimate concern here. So I've got here the cycle continues. Inappropriate sexual behavior, most often reported in teens and adult females, put them at high risk for unplanned pregnancies because of the promiscuity and the inappropriate sexual advances. Increased odds of alcohol and drug problems. So women with FASD are at a higher risk for taking drugs and alcohol. They also have increased chance of females with FASD producing additional alcohol-affected children. Look at this study by Kellerman. In a sample of 100 females with FASD, 30% had given birth, 40% had drank during the pregnancy, more than 50% no longer had the child in their care, and of their children, 30% had been diagnosed or suspected of having FASD. So the cycle is continuing, and we need to do something about that. So what are predictors of inappropriate sexual behavior in individuals with FASD? First off, being a victim of sexual assault or abuse, high correlation. If you're a victim, you're more likely to demonstrate or display inappropriate sexual behavior. 94% of females in their study, this is Strauss, in their study found that 94% of women had inappropriate sexual behavior, also had experienced sexual assault or abuse, against themselves. A stable, nurturing home is the most influential in terms of protecting individuals from or stopping or minimizing the amount of inappropriate sexual behavior. So this is really important. I think this is the key to our whole presentation today. There is hope. I mean, the fact that if a child who has FASD is raised in a stable, structured environment, their chances of inappropriate sexual behavior goes down threefold to fourfold. So we know that there's some things in that environment that do help. It's not like everything's lost. So we have to keep that in mind when we start thinking about programming and intervention strategies. So let's talk about sexual health approaches. Yes. Of course.
Question here. Okay. I'm the only one here, I think, that's a parent of a 15-year-old girl. So the slide with the comment about worrying about his daughter being a victim, well, that's exactly,
it hits homes for you, right?
That is exactly where I'm at when I look at my daughter now, approaching that. She'll be in grade 10 next year. And I'm worried already about her being a victim. But the question that I would ask, and there's probably no answer, but the thing I think about is, how do I protect her from being a victim without socially isolating her by not letting her to go out with, like once she goes somewhere on her first real date, I mean, I can't very well sit in the back seat of the car.
No, you can't.
And I have no control, but again, you try to teach them, but they can't always retrieve the information. So, I mean, she's a lucky kid, really, because she doesn't have any of the risk factors for secondary disabilities. She's in a stable home. She's had services, up yin yang, everything I could possibly get for her, she's had, as far as protective services, teaching her things, a mentor, you name it. But again,
what you're saying is perfect segue to later on. I'm going to have another slide of a mom giving some suggestions on how to deal with her children.
Oh, good.
And I'm going to question you, because you're my only live audio, in terms of, do you think what she's suggesting is right? And there's this real balancing act. You want your child to have a happy development, and you want her to have some experiences so she does develop her healthy sexual identity. But at the same time, you don't want her to be victimized, right? And that becomes a real, how do you balance it? And what's your name, can I ask? Bliss. Bliss, later on when I bring up that other slide, we'll continue on that discussion. Okay, and you're right, there's no right or wrong answer, but I think there are some possible strategies that we can take, and you've already done a lot. It sounds like you've given your daughter a nice, stable, nurturing home situation with lots of resources. So right away, I'm sure you're not seeing a lot of inappropriate sexual behavior.
I'm not seeing any.
And you know what? There probably are, but you probably, she's probably exactly.
But I know she's a very huggy, touchy person, and some of the people who've worked with her, have set up, boundaries that you have to ask for a hug. You can't just come and hug me. You have to ask.
Wonderful.
Teachers and so forth. But again, will she be able to pull that out
when the boys ask for hugs?
When the first boys start asking.
No, you're right, and we will talk about that, I promise. Okay? So what we're going to do in this is talk about sexuality as a human right. We're going to talk about medical versus sex-positive approach. We're going to talk about why we as service providers are hesitant to deal with the whole area of sexuality. And also, parents' need for support and services and reassurance. So the first thing I've got here is we live in an attitudinal umbrella of reproductive bias regarding sexuality. What do I mean by that? Any suggestions? We live under an attitudinal umbrella of reproductive bias regarding sexuality.
Women and men are treated differently.
Yes, that's part of it. Yes, what else?
Well, if you have a disability, you're not entitled per se.
Wonderful.
Bias would come from.
Yeah, I mean, people with disabilities are not sexual, right? They're not supposed to be sexual. And Dorothy, as we were walking here, we were in the wrong place before this, and we walked from the other building here. You had mentioned about eugenics, and there's this attitude around that. But there's this attitude that people with disabilities should not be procreating and they shouldn't be having sex. And you shouldn't talk to them about sex because if you do, it's only going to lead to inappropriate, negative sexual behavior. So better to treat them as asexual.
Well, this province has a history
of
sterilizing
for sure.
mentally handicapped individuals. So.
Most definitely. So in our society, the only people who are treated as sexual, and they've done actually general studies with healthcare professionals, and the only people that healthcare professionals tend to broach the topic of sexuality is in young, healthy, or going to be healthy, heterosexual married couples. Because they, our society says, are allowed and supposed to have sex. And of course, only to have children, right? But in reality, we're all sexual. Whether you're children, whether you're adults, whether you have a disability, whether you're, gay, lesbian, on and on and on. It doesn't matter. We're all sexual. But we have this attitude that only certain people should get services or support or education around sexuality. So that's why I put up this slide, is to bring about this awareness that we do tend to treat people with, for example, FASD as asexual, as children who don't have a sexual potential or a sexual future. All right, so sexuality is a human right. Historically, individuals with cognitive or developmental disabilities have been portrayed as sexually threatening, requiring professional management and control. All right? Now, there's a paradigm shift. Initially, the early approach was any form of sexual expression should be eliminated. If any behavior came up, boom, you stop it. You don't want it to happen. Okay? It was control, control, control. Then they said, you know what, that's not working because all it led to was a lot of inappropriate stuff happening behind the scenes. They said, okay, let's allow some sexual expression, but it's under our rules, our control, and it should only happen at certain whatever times. And I did a presentation a week and a half ago in Red Deer at the Dual Diagnosis Conference, and we talked about that. And there was one example they used where in this one facility, this man and this woman from another facility were dating. And what they would do is actually bring him over to her facility for basic conjugal visits. So basically, they could only be together when the staff deemed it appropriate, and they couldn't choose. So it was at, like on a Wednesday afternoon at 2 o'clock, they're going to have sex. Like, if I told you you're only allowed to have sex on a Wednesday afternoon at 2 o'clock, how would you feel about that? I mean, is that, respecting their rights and dignity? Can they look at other options? So the new philosophy is sexuality and sexual gratification are a major life resource. It can enhance the quality of life, and individuals need to be taught. And what we're also finding is when you do take the proactive approach, you'll find that actually inappropriate sexual behavior actually decreases. Now tell me, most of you are either parents or working in the area. You'll notice that there's lots of programming in place for individuals who have cognitive disabilities, developmental disabilities, FASD, can be part of that whole group, mental illnesses, lots of programming in place when it comes to sexuality. Can you think about the philosophy of these programs? If you were to lump them all together, do you see a similarity in all the programs? Any suggestions or ideas? Control? In what way?
I think what they teach is restraint, control, keeping the urges
Okay,
in.
good. That's a perfect answer. And because I actually finished a project looking at developing sex education guidelines for children with physical disabilities. Initially, I was going to look at all children, and then when I initially looked at all my literature, I found a significant difference between children with physical disabilities and programming for children with physical disabilities and children with cognitive, intellectual, mental illness issues, etc. I found lots of programming for that group, none for physical disabilities. So I decided to focus my research on physical disabilities initially. You know why the children with physical disabilities didn't have any programming in place? Because they self-limit. Because a child, let's say, who's got a spinal cord injury or something like that, cognitively, he's all there. He knows that he shouldn't touch himself. He knows that he shouldn't bring up the topic of sexuality because he's just going to be treated badly. He knows all of this stuff, so he self-limits. Us in the general population and teachers and service providers go, whoo-hoo, this is not a problem because they're not bringing it up and it's not an issue. Parents don't have to worry about it because their kids aren't talking about it. It's really not an issue. It's a dead issue, so we don't need programming for them. Then you have this other group of children who have cognitive impairment, mental illness, FASD, all of those can be put together. They're doing inappropriate sexual behavior. They're touching themselves. They're doing all the stuff that is, what's the word for it? It causes discomfort for staff, parents, society. Oh my God, they're touching themselves. We need programming. We need to control their behavior. So that's why you see lots of programming for these individuals as opposed to physical, because the idea is to control. But if you look at this, that control is, and you know what? It's with good intentions because it is approaching things from a medical model. So we're talking about harm reduction. We don't want them to get abused or assaulted. We want to prevent them from getting an STI or HIV or anything like that. And we also want to protect them against unplanned pregnancies and assault. So we're doing this because we want to make things better for them. Right? It's good intentions. But the problem is we're not helping them enhance or actually develop their sexual identity. So my suggestion is we need to approach things from a sex-positive approach, even with any population, whether it's FASD, developmental disability, it doesn't matter. So sex-positive looks at quality of life and enhancement. So I've got some definition of what a sex-positive approach would be. First off, it looks at a sex-positive approach is a comprehensive definition of sexuality. Remember that first slide I showed you with the diagram and all that, where it looks at sexuality, looking at values, beliefs, and body image, and self-esteem, and socialization, and identity, roles, all of those things? That's what we're talking about here. Sexuality is more than just intercourse. Okay? viewing sexual health as a basic human right, focusing on both the life-enhancing aspects of sexuality as well as the negative. So when we talk about sex positive, we're not saying don't talk about the abuse, assault, STIs, and all that kind of stuff. What we're saying is it should be part of the big picture. You talk about that, but you also talk about sex can be wonderful. You develop a relationship. It can really help you feel like you belong, and it can be really a life-enhancing thing. So talk about both the positive and the negative. And also being non-judgmental and looking at sex as a narrow construct. Sex is so many more things. It's who you are, how you dress, how you interact with people. So sex positive has been shown to actually be more beneficial in actually helping people make decisions and actually have better, appropriate sexual behavior. Other things about sex-positive approach is using inclusive language, right? Everybody's sexual. And using words as something like partner as opposed to husband, wife, etc. We don't want to get into gender stereotypes or sexual, based on sexual orientation. Also, we want to be a sex-positive approach gives choices. So we can talk to the individual and not just say, let's imagine they don't have the consensual ability to, or they're not prepared to have activities such as intercourse. But you still talk about intercourse. But maybe you talk about, well, right now, maybe you should be looking at developing a relationship where you hold hands, maybe kissing and all that. But let's not get into, intercourse and all of that. But you still talk about the whole thing. You talk about what is the breadth of activities that they may be able to do. All right? And we'll talk about consent in a little while. Now I've got here, why do service providers and parents not address sexual issues? Biggest problem? Lack of knowledge about sexual issues. I guarantee you, after today's session, most of you will be more likely to actually talk about sex. Actually bring it up with your clients or kids. They feel ill-prepared to deal with the sexual issues. For one thing, not knowing what to say. Other thing is they're afraid that when they say something, it just opens up a new can of worms, and then suddenly you have to deal with all these other things that come up, and you don't know how to deal with it. Do not know how to initiate discussions on sex, right? As simple as talking about birth control or anything like that. How do you bring it up? Because there's this attitude from a parental bliss, I'm going to pick on you, but from a parental attitude, and I have kids myself, from one perspective we think, I want to keep my kids pure, virginal, keep that purity and this, this image of your children that they are this wonderful, non-spoiled thing. And if I talk about sex, I'm almost initiating them becoming corrupted. You know what I mean? We almost feel like we need to protect our kids, so we don't talk about it. Because we don't want to be the ones initiating their change into adulthood. At the same time, kids don't want to talk to their parents about sex because they want to be seen as this pure, nice child. It's just like you look at the general population. 50% of high school kids, by the time they finish grade 12, have had intercourse. And it's even higher for oral and all that kind of stuff. Only 4% of parents think their kids are having sex. There's a disconnect there. I don't know if the ostrich where the parents are just, avoiding the whole thing. But bottom line is, parents and children don't match up in terms of their perceptions around sexuality. But we do feel uncomfortable. We don't want to break that thing. Do not consider it important as related to other issues. Sometimes you're dealing with all this other stuff when there's a disability involved that you think sex is the last and least thing to deal with. And the other thing is do not consider their role. Oh, it should be the service provider. It should be somebody else. All right? And I've got here, parents need support and reassurance. Almost all parents, Kellerman found, when they talked to these parents, almost all parents confided that their kids with FASD had exhibited inappropriate sexual behaviors at one point or another. However, they did not report it. They did not talk about it because if they brought it up with their teachers or the service providers and all that, they're afraid that their kids would become labeled. Oh, he's the deviant one. He has inappropriate sexual behaviors. Because there's a stigma associated with sex. And almost like you don't want your child labeled in the school system as, oh, he's the one that did the inappropriate stuff. You don't want the teacher treating them differently. You don't want, attitudes to change. So therefore, parents don't talk about it, which is unfortunate. So I've got here, this is Bliss coming back to that slide I was talking to you about. I picked this up off the internet. I love checking out the internet to see what kind of good information is out there and what kind of misinformation is out there. And I want your reaction to this. Response by a mother to another mother regarding a 12-year-old son with FASD and inappropriate sexual behaviors. These were posted on the internet. What are your thoughts? Put alarms on the door and windows so you can track his movements at night. Don't expect him to have the natural boundaries that most people have for appropriate behavior. Protect him from crude, vulgar, criminal, and sexualized people, behavior, language, and visuals. Don't relax supervision and structure just because he's reached a certain age.
One word, yikes. I don't think that is, personally, I don't think that is the way to go.
Mm-hmm. What do you guys think? Any other reaction?
Well, it makes it sound like sexuality is deviant behavior.
Yeah. And I mean, this is her child. It's not a prison. And yet she's treating their home like a prison. Remember that part where I talked about a nurturing,
To me,
you know.
it's a fear response.
Yeah, it is a fear response.
I got to do everything to prevent it response, whereas, you know what, really, you're not preventing anything anyway.
Yeah. Now, Bliss, with your daughter who's in grade 10, you talked about, oh, she's going to start dating and all that kind of stuff. What are you going to do? Sit in the back seat eating popcorn while they're...
No, I'm
You're
not.
not, right? But you could lock her up and not allow her to go out and all that kind of stuff.
See, that's not really going to help either. is
No.
it? And that was my question. How do I lay a foundation to protect her
Mm-hmm.
so that without, sort of, what was the word I wanted? Isolating her.
Yeah.
There has to be a healthy middle ground where she's not isolated. She still can have friends and even boyfriends.
Mm-hmm.
I'm kind of not showing a huge amount of interest. Well, she has a boyfriend, but I mean, they only see each other at school right now.
Mm-hmm.
But, there has to be a healthy middle ground, and there has to be a good groundwork laid, really. And the tricky bit is, again, it always goes back to, will she be able to retrieve that information when the time is upon her?
I think you should be up here with me. Honestly, that is probably the best answer I could have given, because you want to find this healthy middle ground. You want to allow, and I think you're approaching things from a more positive manner. You're not trying to control, but at the same time, you're being protective. But now, the problem is, and we'll get into sex education next, how do you ensure that your daughter has some experiences, but is still protected and not being manipulated, coerced, or getting into things that she doesn't want to do, but she's being forced to do, right? And that's scary.
Exactly, and I don't want her to be talked into. My fear is that she will get talked into something she really doesn't want to do.
Yeah. Mm-hmm.
That's what I worry about.
And that's, again, just like that other slide I put up with that father of a 12-year-old. So let's talk about some barriers, because we do want to enhance sexual expression. We want, from a sex-positive approach, our goal should be to help these individuals develop a sexual identity, something that's appropriate, that society deems as appropriate, that allows them to develop relationships, develops and enhances their life, all of that. But there are barriers. And here's some barriers, and I'm not saying it's right for every single child or every single individual with FASD, but these are some general trends that you'll see. First off, individual or personal barriers. Now this is, let's imagine that you start saying, you know what, I think it's important to develop this person's sexual identity, and you try to approach things from a very sex positive, allowing them some opportunities for expression and all that, and you hit it feels like you're hitting a wall. Boom. They're very hesitant. They're very almost causing conflict, because remember, a lot of these individuals have a history of abuse or trauma. Okay? They themselves have had some very negative situations or experiences. So sex to them is not a wonderful thing. So when you're trying to help them develop a sexual identity, they've already had bad experiences. So it's almost, you're not starting at stage 1, you're starting at stage -10. You have to get to stage 1. While most able-bodied kids, you're starting at age probably stage 2 or 3. You see how you need to almost, it's even more work? They lack the confidence and self-esteem that impairs their ability for intimacy. Because again, they've got a lot of negative responses or reactions from people. Medication side effects can also affect what's happening to them. So they're taking meds that's for their disability, but it also has sexual side effects that affects them, that prevents them from functioning normally, so they know things aren't working as they should. Certain symptoms, like poor social development, inhibit ability to form relationships. They don't know what's appropriate behavior. So when they try something, they get shut down, so they don't even bother. So then, sexuality means physical activity as opposed to the relationship stuff. Okay? Lack of ability to comprehend, need for emotional intimacy, but still has a physical drive. And that's what I'm talking about. A lot of times for individuals with FASD, sexuality is the physical stuff. How to have an ejaculation, orgasm, physical intimacy, not the relationship intimacy that is probably just as important. And past indoctrination that sexual expression is bad, inappropriate, and will be punished. So if they've grown up in a situation where they've always been told sex is bad, and then you try to say, no, sex is good, again, you're at stage -10. You need to get them to stage 0 before you can even start doing something productive. So that was personal barriers. So you're starting off with somebody who's already has problems because of their experiences and all that. Then you're looking at attitudinal barriers. Parents, staff, service providers, all of them have often have attitudes and practices that deny the right to healthy sexual expression. So they put in place certain procedures, policies, and also their attitudes that prevent sexual expression, healthy sexual expression. Parents of adolescents with physically or developmental or intellectual diagnosis are less likely to allow their children to go out and socialize. They're more likely to control. So these kids aren't getting the same opportunities with other kids, all right? More likely to have limited circle of friends and social contacts. So they have less friends and individuals they can interact with. Because remember, a lot of things that we learn are through interaction. And these kids are very limited in their interaction. Other things. Individuals living with such disabilities often acquire sexual knowledge and experience and feelings from different sources and compared to their non-disabled peers. Like I said, we all learn from schools, family, TV, all that kind of stuff. Individuals with disabilities tend to get more formal sex education if they do get anything. But that's the limit of their education. Now remember, if they're getting sexual education from a formal source, from a person who has a very negative attitude regarding FASD and sexuality, they're going to be taught, you don't do this, otherwise you're going to get a horrible disease. You might get pregnant. Someone might abuse or assault you or hurt you. So don't have sex. That could be still considered formal sex education. So again, it's actually making the problem worse rather than better. All right? And also, the whole topic of sexuality is less likely to be normalized because it is not discussed. Okay? So there's a lot of attitudinal barriers. The last one is structural barriers. Okay? Individuals with FASD living in group home situations or institutions or whatever, a lot of times the organization or institution has certain policies in place that prevent sexual expression. And these are part of the guidelines. As a new staff member, you come in and you're taught, don't let them do this, don't let them do this. So there's a lot of control in terms of rules. Social isolation and protection. They don't have the opportunities to interact with others. Okay? And when they do interact with others, the interaction is functional rather than social. Okay? You need to work together to sweep this floor or do this or do that. It's very functional. A lot of times when you meet with your friends, yeah, you might be doing some work, but other times you just sit there and talk and interact. It doesn't happen with these individuals as much. Individuals are segregated in settings. So boys are in one end, girls are in the other. Again, for safety issues. So they're not allowed to, or do not have the opportunity to form relationships. Another thing is adults living in community settings that are set up. A lot of times they're put into situations out of convenience. Oh, you're the same age as Joe, so you and Joe are going to live together in this group home setting or whatever. Maybe he doesn't like Joe, right? Or it probably it's a situation where it doesn't allow him to develop any sort of sexual identity or expression. And finally, families or agencies may intentionally try to keep them from participating in intimate relationships. So it is an active process, not just a passive one. Any questions before we move on to the final part about what do we do now? Okay. All right, then let's talk about sexual health intervention. Why is it important? We're going to talk about that. We're going to talk about self-control and what are the issues around that, and what interventions are going to work. What types of things are going to work with this population group? So first off, why is sexual health intervention important? Okay? It plays a major role in the individual's overall self-identity. We find, and we're not just talking about people with FASD or any other sort of disability, just the general population, you and I, the more sexual health education you have, the stronger your sexual identity. The more likely you're going to make good decisions when it comes to sexual activity. All right? And that's the same whether you have a disability or not. Okay? So it is critical. Developing a healthy identity requires you to make decisions to control one's life and build relationship with others. So having a good sexual health education or intervention allows you to do that. And also, to engage in fulfilling sexual relationships, people must experience a range of feelings and emotions. And bliss, when you talk about your daughter, that's part of that, right? I mean, she needs to experience being with a boy, being on a date. She needs to do that to be able to see what's good and what's bad. And you know what? Some of the dating situations may not go well. She goes, boy, was he boring. I didn't like that. That was silly or whatever. Other things was, oh, I like that. And she'll start to decide what's good and what's not for her based on experience as opposed to what you tell her. Because you tell her, she's not going to listen, right? Hopefully. I mean, maybe she'll listen, but you never know. Now, when you're looking at sexual health intervention, you need to consider cognitive deficits, the fact that these individuals are impulsive, and lack of ability to delay gratification. Now, think about it. When we, all of us, when we think about sexuality, I mean, yes, sometimes we're turned on, we want to be sexual, but you're at work or you're at a social situation. You can't be sexual at that point. So I say, you know what, I'll wait until we're home and then we might do something, right? We know how to delay immediate gratification. It's just like children. Yes, you have a box of candy there, but you don't eat it now. After you have your dinner, you can have dessert. So children also learn to delay gratification. It's part of our sexual socialization. But also impulsivity. Those things go hand in hand. So if you have an urge, you jump at it. And you want to gratify, you want immediate gratification. So these two put the person at a high risk for inappropriate sexual behaviors. Okay? And improving cognitive function has been shown. So sometimes we focus on the sexual behaviors when rather you should be focusing on the cognitive behaviors. So you help with the cognitive functioning, and guess what? It'll help you with dealing with the inappropriate sexual behaviors. You need to understand cognitive functioning before you start dealing with all the sex stuff. So you know what level they're functioning at so that you can make it appropriate and relevant. Now let's talk about self-control. Deficits in response inhibition imply limitations in capacity for self-control. A lot of times when a child or an adult with FASD does something, inappropriate sexual behavior, right away say, oh, he doesn't have self-control, right? Right away we label them as not having self-control. However, remember what I talked about? Kids tend to have less inappropriate sexual behavior because they're being watched, they're being supervised. They have cues. Now that tells me, and it's shown that individuals with FASD, if they're in a controlled situation, they're less likely to have inappropriate behaviors or inappropriate sexual behaviors. So that tells me there is some form of control happening. What you're trying to do now is try to figure out how can we put that control in and the cues and all that in without locking them up and putting alarms in the doors and windows and all that kind of stuff, right? Now I've got here, but what if there's a neuropsychologically a limited capacity for self-control? Impact of external cues to help self-control. So they can't do it internally. They need external things to control their behavior. So that makes it much more difficult. So I've got a thing here. My son acts out sexually most when he is overstressed, overtired, or I'm gone. He can quote the rules, knows them all, will tell you afterwards what he did wrong, but it still doesn't stop him. We are in mom-enforced lockdown, and he does know why, but it doesn't make it any easier for any of us. This is a perfect example of how the child knows what's right or wrong, but is still doing the wrong thing because of impulsivity, immediate gratification, poor processing of information, poor ability to look at consequences, all of those things coming into play. So what do we do about this? So what interventions are going to work? Now look at this. In 1996, Weinberg and Gurry wrote that there was no intervention for individuals with FASD for any age that has been scientifically validated. So what do? Stop? No. Luckily, there's some more new recent thing. I've got here, if you keep doing what you have always done, you'll keep getting what you've always gotten. A lot of times, we tend to do the same thing over and over and over again. What research is showing with FASD, if you keep doing what you've always done, you're always going to get what you've always gotten. So in other words, if it's not working, don't do it. If it's working, do it. All right? So let's look at strategies for dealing with inappropriate sexual behavior. Okay? So we're going to talk about strategies for dealing with behavior, helping individuals with FASD express this sexuality appropriately. Just seeing how much or where we are at. All right. General treatment recommendations found in the literature, I looked at them and I said, that's common sense. Okay? And I think Bliss, I'm picking on you because you're experiencing this, having a child with FASD. But you probably see that probably some of the most common sense things work, don't they?
Pretty much. And yeah, that's true. And like this little comment here, my son acts out sexually most when he's overstressed, overtired, or I'm gone. I can see that in my daughter. Mm-hmm. In every area of her life. She rides the bus to school. She goes to L.Y. Karen. She's in a special school. She rides that bus home. And I can see her when she comes home, she has spent the whole day kind of trying to keep it under wraps, stay within the boundaries, and that uses up a tremendous amount of her energy. And the kid comes home, and I can just see her. She's just beat. And when she was little, she would come home, and after a whole day of being at school, she would be just busting out, and you could see her suddenly let go of the controls, and she'd be bouncing off the walls. Mm-hmm. And it's the same thing now. You come up with strategies that work, and that's what you do.
And I want to add something to that. When Bliss is talking about control, keeping it, everything together during class or during school, and she comes home and everything's like, and it is a lot of
She's trying
energy.
to relax.
There is a lot of energy being, but controlling, not saying something stupid to the teacher, not saying something inappropriate to a classmate, being properly behaved, all that is different from control when it comes to sexual activities. Because now when there's sexual activities or sexual impulses, there's that hormonal issue going on. Okay? Now, I'm not going to ask you guys all to share or anything like that, but think about yourselves. You know, sometimes our brains take a holiday when we're kind of turned on and things like that, and we do things that maybe we shouldn't. But it's part of our innate human way of dealing with our sexual drive and all that. So individuals that, with FASD have even more of a difficult time. So they might have control in general situation, but when they're alone with their boyfriend in a car somewhere, it becomes a lot more difficult. All right? So, first thing, common sense. Intervention should be concrete, redundant, with lots of time for practice and repetition. So remember we talked about abstract versus concrete. So for example, an abstract thing would be, you shouldn't be alone with the boy in a car, and you shouldn't go into the back, you shouldn't be alone, and just keep it at that, as opposed to, coming home, I will pick you up. You guys can go to the movie, but I will drive you home. When you are, being very specific, if you decide to hold hands, if you do, being very specific in what is acceptable and what is not acceptable behavior, right? So you won't be concrete. Redundant. So you want to say it several times with lots of time for practice and repetition. It is shown that if you just tell somebody with FASD or development delay and all those disabilities, they're not going to listen. They're not going to retain it. They're not going to take it in. But if you tell them and then you actually say, okay, let's try it out. Let's imagine I'm your boyfriend and I put my hand on your leg and I start unbuttoning your shirt. What would you do? This is what you would do. Take your hand and actually get them to practice. Move the hand away and what to say. Okay, let's try it again. What to say. So what you're doing is actually giving them the skills on what to say. So it becomes an automatic thing as opposed to something they need to recall and whatever. Okay? It's like playing sports. If you ask somebody who's playing basketball, how did you make that shot? They don't sort of say, okay, I'm going to think about it, I'm going to make that shot, I'm going to bend my wrist and that. No. It's in. They don't think about it because it becomes a natural thing. You want that same sort of approach with FASD where it becomes a natural fluid activity as opposed to something they have to think and bring back experiences and consequences and all that. Does that make sense? All right, the next one. Matheson found that persons with FASD fail to benefit from repeated exposures to verbal materials over 5 acquisition trials, showing most of their improvement in the first 2 trials. So if you do it once, great. Repeat it again, great. After this 3rd time, you're wasting your time. What's suggested is you say it once, repeat it again, but then use other forms of delivery, whether it's demonstration, whether it's show and tell, whether it's whatever. But don't do the same thing over again. If you do what you've always done, you always get what you've always gotten. So what you're trying to do is try different approaches. An activity-based approach is really good. So where the child or the person is actually doing some hands-on physical things along with hearing you, with what they should do. That tends to work the best. Assess overall functioning to ensure unidentified impairments do not hamper with the learning. So if they're not able to learn very well verbally or visually, then how do they learn? So you need to have them, whether you get a professional to do it or you yourself look at what is the best method for them to learn and then use those methods. And the other thing is medication management. It is not always the last resort. Sometimes it's a first resort. You'll find sometimes medications really help and may actually increase the person's capacity to actually follow through on treatment. So don't be afraid of medication. Sometimes it's a good option. Okay, so strategies with, dealing with sexually inappropriate behavior. I've got it as SMART. We use SMART goals when I work with the occupational therapy students and all that. But what we're talking about here is any strategy you use, keep it specific. So don't try to cure the world. So for Bliss, she might say, okay, the first thing we're going to be, our specific focus will be dating. And we're not talking about dating in general. We're talking about, oh, Saturday night she's going over with George, I'll make up a name, and they're going to a movie. So that's going to be a specific scenario situation. Measurable. What are you trying to do? So basically think about what are your goals of your little education or treatment or whatever session. What is your outcomes? What are you're trying to make sure that Bliss has a good time. I would say not Bliss. Your daughter has a good time, but at the same time, she's not being put in a compromising situation. Attainable. Is that possible? Yes, it is. You don't choose goals that aren't ready. Is it relevant to Bliss? I would say your daughter. Is it something that she would think is important to her? And I think it would be, because what you're saying is, hey, this is great. You're going on a date. I'm all excited. You're all excited. But let's work on it together. And she'll want to buy into that. And also, time-based, because you don't want to try to talk about something that's going to happen way in the future, whatever. You want something that's measurable, that you can do, and we're going to talk about it and work on it and have very specific timelines. And then when that's over, you sit down and you evaluate it and then say, okay, next time what do we do? So you start over. And unfortunately with this group, you need to do lots of reevaluation of the strategies and try something different. So I've got here, helping individuals with FASD express their sexuality appropriately. There's no right or wrong answers, but keep it professional. There's no right or wrong person to do it, but somebody should, whoever has the best relationship. Provide opportunities for expression. And also, the needs for men and women are different. You know how we try, when I teach sex education just for general, you say you should do equal. But when you're looking at FASD, the needs of girls with FASD are different from boys because of the type of behaviors they tend to get into. So for girls, you want to go more into, this is your body, this is how you protect your body. It is not open for everybody. While boys, you're talking about respect and saying that you have to get permission for touching and any sort of sexual advances. Helping individuals FASD express their sexual, become aware of your own comfort and discomfort zones, find strategies that work for you. And also, the key thing is do lots of sexual health education. And that's what our next focus will be, is looking at sexual health education. So what we're going to do is talk about sex education now, because I think this is a critical component of safety or preventing or ensuring safety of individuals with FASD and sexuality. So what are some benefits of sex education? Self-esteem and empowerment. Kids who have sex education, whether they have a disability or not, who have a good, strong foundation are more likely to make good decisions. They're more likely to not get into inappropriate sexual behaviors or not get into situations where they might be manipulated or coerced or whatever. They will be more in control. It also teaches them skills. Sex education should be a skill-building activity. Improve communication, so they'll be able to discuss and tell things. They'll be able to set the stage for different activities. They'll be able to articulate what their goals are when it comes to sexuality. And finally, they'll be able to prevent negative outcomes such as abuse. Have I sold you on sex education? I hope so. So what areas? I'm just going to quickly read through these, but some areas that we need to address for FASD is rights and responsibilities of sexual behavior, dealing with current relationships, sexual interaction and behaviors, social skills like assertiveness, orientation, lesbian, gay relationships, all of those kinds of things. Body part identification, pregnancy, childbirth, abortion, sexually transmitted infections, contraception strategies, what works best. masturbation, sexual abuse, personal care and hygiene, puberty changes like menstruation, and finally medical examinations, what's appropriate. So these are some topic areas that need to be addressed when it comes to sex education. Now, one of the things is treating this population as asexual or as children is ingrained in much of our society. The problem is, if they're treated as children, guess what? They'll act as children. But you can't. Accurate, age-appropriate information. So basically, when you're doing sex education, you must give information that's at a level tailored to their chronological age. Now, what do I mean by that? You should be giving sex education at a level that, so for example, your daughter who's grade 10, you should be talking about intercourse and all of it. All right? If your daughter was in grade 6, then maybe you don't need to get into all the details about the actual activities. You might talk about how babies and, da-da-da. But you have to keep it at their chronological age. However, teach to express physical affection that is appropriate to their apparent age. So if you have a child or individual who chronologically is 18, but intellectually is maybe at a 13-year-old or a 12-year-old, you talk about expression at the apparent age, so at a 12-year-old level. Does that make sense? But you teach them sex education at their chronological level. So you teach them about birth control and all that if they're 18 or 16 even, but expression should be at their intellectual age, apparent age. Does that make sense? That's a critical issue there. Teach methods and tools. Teaching methods should be at their intellectual age. Again, we should be concrete versus abstract. And remember, context is everything. What is appropriate in public is not, what is appropriate at home may not be appropriate in public. So talking about that from that perspective. Teaching sexuality is a positive and pleasurable thing. Do not make the mistake of saying only the negatives. You'll get pregnant, you'll get STI and all that. Talk about sex can be a wonderful thing if it's shared, respected, and done appropriately. So keep it, don't be afraid of the positive. Discourage inappropriate displays of affection. So if, for example, they do something that's inappropriate, catch them on it. Say, you know what, that's not right. That's inappropriate. Okay? I work with a man with a disability, for example, and at times some of my students work with him, and sometimes he may say something that's inappropriate. And I tell my students, if he says something that's inappropriate, tell him. Okay? Express clear behavior expectations that conform with families and societal standards. Recognize the importance of feelings. Practice appropriate affection. This is important. Now, you have somebody with FASD. And let's imagine for them, sexuality is physical gratification. They have no appreciation or no motivation to experience affectionate areas. You still want to practice it. So what you might say is, okay, you're going on a date. I want you today to hold hands. I want you to talk to the person. And they said, I don't like doing that. You get them to do it anyway. Because a lot of times they have not experienced affection and appropriate affection and all of that. And you know what happens? If you get them to do it, practice it, even though they don't want to do it, what happens is they might get reinforced and say, hey, that's kind of nice. Or they might see some benefits for that in terms of the other positive benefits of just interacting with somebody. And then guess what? They'll start to do that on their own. Okay? So you want them to practice appropriate affection. It does not always mean intercourse, physical activity. You're talking about holding hands, sitting there and actually just talking. All right? Teach the difference between acceptable behaviors in public setting and those in private. Home should be a safe environment. And I like what Bliss said. When she comes home, she just can, and that's okay. Home should be a place where they can be themselves, right? Teach the right to refuse to be touched. two kinds of common mistakes: public versus private errors, and stranger versus friend errors. What can you do with friends compared to what can you do with strangers? Discuss pleasure and affection when educating about sex, and I've already talked about that. Sex education suggestions for practice. This is an important one. Masturbation. Oh my God, when you think about masturbation, we all go, it's sort of this icky thing that we don't want to talk about, that's so personal and private and all that kind of stuff. But individuals with disabilities and FASD, they've actually shown that training these individuals on appropriate masturbation and actually doing it when it's appropriate and all that, if they get into a habit of meeting some of their sexual needs that way, for the physical urges and all that, their impulsivity, their immediate gratification, and all those kinds of things, promiscuous behavior and all that, will drop. Because now they're getting an outlet that's in a safe, controlled environment, and that. So actually, instead of avoiding the topic, masturbation training should be something that should be part of your approach. You know, masturbation is a wonderful way of meeting some of your sexual needs, but it should be done in private. This is what you should do, da-da-da. There's even actually videos that you can get on how to train somebody on how to masturbate. And we're talking about both men and women. Sometimes we always think, oh yeah, we need to teach the guys how to masturbate. No, also teach the women. Their promiscuous behaviors and will also decrease. Another thing is being open and honest. You know what? People are going to treat you differently because you have a disability. People are going to try to take advantage of you. People are going to try to do some negative things to you. But that shouldn't stop you. What you should look at is being careful. Okay? So you don't stop it there and say, that's why you shouldn't be, think about sex. But what you say is, when you do decide to get into a relationship, you have to be careful in some of the things you need to worry about. Does that make sense? Okay, specific safety education and treatment programs. You need to provide information on safe sex and sexually transmitted infections. Now, there isn't a lot of specific literature on this group, but when you're looking at cognitive impairment and mental illness, these groups tend to have the highest rates of unplanned pregnancy, HIV, STIs, and all of that. All right? Even though they're getting a lot of programming when it comes to sex education about contraception and all that kind of stuff. So what that tells me is these programs are not working. So when it comes to FASD, yes, you want to provide information, but information saying, if you have sex, put a condom on. If you do this, use protection. You must be on birth control, otherwise you could get pregnant. It doesn't work. So now we go back to our common sense approach. When you're looking at contraception, so tonight, if you decide to have sex, this is what you're going to do. If he starts to, take off your clothes and you want to have sex, here's some condoms. You do not let him touch you unless he puts this on. If he says, oh, but it doesn't feel right, and you're on the pill, so you're safe. No. Have some very... So you're saying, do this, but if you're going to do this, this is what you need to put in place. Tell him twice. After that, it's not going to, it's not probably going to work. So what you want to do is say, okay, you tell them twice, make sure they understand it. Next, put in cues and very specific. When he does this, this is what you do. So what you're doing is setting up the cues based on the other person's actions. Does that make sense? Okay. Teach techniques for managing high-risk situations. Again, the same approach. Explain, give them the information, but then also give them the skills to deal with that information. Telling them is not enough. Skill building, demonstration, as simple as condom use. How do you do it? Put it on, etc. But you know what? Teaching how to use a condom is one thing. Negotiation about getting them to use a condom is another. So it has to be the whole thing. Teaching clients to develop personal awareness of their own high-risk situations. So you do role play, behavioral rehearsal, and modeling. So you might show them and then get them to show you. Okay? It can be quite threatening because, you know, it's sometimes embarrassing and things, but you need to deal with it. So I've talked about so far what are some of the issues. You know, what are some inappropriate sexual behaviors? What are some barriers to sexual expression? Why sexual health intervention is important? And the fact that sex education and the areas you need to address. And I've talked about approaching things from a sex-positive approach. However, now the problem. What if your client does not have the capacity to make good decisions? What if they don't have the ability to consent? Now in Canada, anything between two consenting adults is legal. The problem is when you have the inability to give consent, how can you participate in sexual activities? Okay? So the last section I'm going to talk about is consent, because that's critical. I mean, if a person is not able to give consent, should they be participating in any sexual activities? So by definition, consensual ability is capability to give informed consent to sexual contact. Notice I had the word informed in there. Informed means if they're going to have intercourse tonight, informed means they understand what intercourse is, what are the consequences of intercourse. Intercourse is where a male puts his penis in my vagina and da-da-da-da. And if I don't use protection, I could get an STI. I could get pregnant. Intercourse can be very pleasurable. For some people, it might be a little painful if it's the first time, da-da-da. So the whole range of things around intercourse. That's what informed consent is. It's not just intercourse is having babies or whatever. It's the whole consequences and all the aspects, both positive and negative. So when you're evaluating an individual's consensual ability, it should address a person's ability to make decisions based on knowledge of the nature of the sexual contact, possible consequences, and social and moral context in which it occurs. Now, what we're talking about here is social moral context. For example, who should be having intercourse? Now, if I went around here, and I won't do you, but in my class I do a values clarification exercise, and I had this activity saying, premarital intercourse is, and I get the students to just throw out answers. And you know what? Some say premarital intercourse is wrong. Some say it's wonderful, expected. You know, you have a whole range of values around it. Now, as a parent or as a service provider or whatever, in some ways it's our responsibility, especially if Bliss with your daughter. I'm sure you're going to be hopefully giving her some values around when it's okay to have intercourse. Now, you might be teaching her you should only have intercourse when you're married or in a relationship, a long term. Or you might say, it's anytime, any whatever, which I hope you don't, okay? But the thing is, there is the moral context of the consequences too. If you start having sex with everybody, people are going to see you differently, okay? So there is that, you might get pregnant and all that, but you also have to get that other aspect. You need to give that information. Contact where one or both parties lack consensual ability may be considered a crime. So for example, if you're in an institution and one person is higher functioning and one person's lower functioning intellectually, the higher functioning person initiating and manipulating the lower functioning person to have sex is a crime. Okay? So be careful of that. And it is expected that staff are required to report all sexual contact between non-consenting adults or adolescents or individuals to the appropriate authorities. So it is against the law. So now we have this problem. We want to be sex positive. We want to allow for sexual expression. But what if my patient or client or whatever can't give consent? What do I do? Should I just prevent it? Because otherwise it's a crime. Right? Now we've got here, sex drive may not match intellectual capabilities. So these individuals have a high sex drive, but they don't have the ability to give consent. How are we going to deal with it? Yeah, I can do masturbation training, but that only goes so far, right? So, going back, the ability to give consent is strongly related to sexual knowledge. So how do you develop intellectual or consensual ability? First off, teach them about sex, so sex education. Next, level of intellectual ability. If it's low, you're kind of stuck. But if it's something that you can develop and whatever, if their intellectual ability is fairly good and you teach them about sex, you can actually improve their consensual ability. Social adaptive age. Not their chronological age. What is their social adaptive age? So they might be 18, but really they're like a 12-year-old. Okay? Participation in sex education courses will, of course, help their consensual ability. So let's talk about graduated/situational consent. So the person might be able to give consent to some forms of sexual activity that do not include, for example, intercourse, which will protect them against pregnancy and infections and abuse. However, is this appropriate? So let's imagine you have two individuals in your facility that want to have activities. They want to have some activities and say, okay, you guys can kiss, you can hold hands, you can do whatever, you can do some heavy petting and all that, but you're not allowed to have intercourse. And they agree to that. And they don't have intercourse. Okay? But really, their intellectual capacity and all that is not at a level where they actually fully understand the meaning behind heavy petting and all that kind of stuff. Should they be doing it? Question to you. Is this appropriate? Because by definition, they're not able to give consent, so what you're allowing them to do is against the law because it's non-consensual. What do you think? It's not an easy answer, is it?
It's a tricky one.
It is.
Because you're not just talking about consent, you're talking about hormonal and part of the whole person model.
Yep.
So that's really tricky. And actually, I was just thinking about this right now because based on Sarah's social adaptive age and her level of intellectual ability, she would not, at this point, she's 15, there's no way she would be able to legally consent, if you look at that.
You're right.
Does that mean I can't let her, that it's really tricky. And I was thinking, well, if some boy and her got into it, technically I suppose I could have this kid charged with a crime.
You could.
But I thought, well, that wouldn't be really right because, I don't know. And that's where the argument broke down. I was like,
But
sorry.
might you have a conversation with the parents of the boy?
At that point, that's probably where you'd have to go.
Like,
and
put
fortunately, we
yourself in
haven't
the
come to
seat
that
of the
place
boy's
yet.
parents too, right?
But yeah, it's
Yeah.
really tricky.
My teenage kids without a disability were having conversations with other parents,
And you know what else that brings up? If let's imagine you went to the boy's parents and said, my daughter has a disability, blah, blah, blah. You know what the parents, suddenly all the biases and all these things are going to come into place. You're not going to date a girl who has a disability.
And there's that.
Right away, they might pull away. So it's a really tricky issue. And I mean, in your situation, it sounds like Sarah's fairly high functioning.
She's not.
She's not.
She's not. She has a very low IQ, actually.
Okay.
She's very low.
So that makes it a difficult situation. A lot of times these kind of situations also come up in group homes and that with very low functioning individuals.
In some ways, it's easier, though, if the child has a more visible disability. I think the trickier part and the more ethical dilemmas come around kids with an invisible disability, where it's not so obvious.
Well,
and
FASD is pretty, well, for her it is invisible, but she doesn't have to talk very long before you know.
Yeah.
You know what I'm saying?
Yeah.
Yeah. But the other thing is because she's low, she's in a special school, her contacts are also kids with some level of disability. So that changes the whole picture too.
Sure. I mean, there's a case where, the boy, is inappropriately touching all these girls. So he's been told, don't do it, don't do it, don't do it. And he stops doing it. Then one day he actually sexually assaulted one of his classmates because, they control to the point where they're not allowing expression. And you want to have that happy balance, common sense. So I've got here, by definition, any sexual contact that is not consensual is considered assault. But we can't be so, cut and dry about it. So Bonnie argues that a person may be competent to make certain decisions, but incapable of making other, even within the same situation. So using Bliss's daughter, let's imagine she can make, she can give consent to kissing, holding hands, and all that, but maybe not to other activities, right? So therefore, she's going to be taught, hopefully with the boyfriend, but not, at what level does she stop? What are her boundaries, right? Situational competency allows arguments that an individual may be capable of consenting to some forms of sexual contact with certain individuals in a particular setting, but not to other forms of sexual contact with the same or other individuals in other settings. So what we're saying is maybe not having it cut and dry sort of thing, but really saying for certain activities and situations, this is okay. Other things, it's not okay. Now, we're behind in some ways from the U.S., but in the U.S., actually, the lawyers have looked at this situation, and they've pointed out that individuals with disabilities, when we're talking about cognitive disabilities too, may be deemed competent in the particular area of sexual activities and relationships when they're deemed incompetent of making decisions about where they live, finances, and all of that. Because there is a difference between sexual activity and relationships as opposed to social things like finances and living and all that. The reason for that is sexuality is part of our innate human nature, and we have a right to express that. All right? But we have to do it safely. So a major issue is that once we make a decision, whether it's as a parent or as an institution, that, Joe is not capable of making or giving consent to sexual activities. If we make that decision, we have basically labeled Joe as being not able to give consent. So basically, we are saying that Joe is not allowed to have any social sexual activities or behaviors. And that's not fair, right? So what I'm suggesting is saying that maybe we should look at situational capabilities. Look at Joe and saying, yes, he's not able to give consent for intercourse. He's not able to consent for this something. He can't give consent to being alone with a girl or a guy or whatever in an isolated situation. But he can do this, this, and this. All right? But that's where it is based on your skills, your attitudes, and your abilities to make decisions based on their intellectual level and all of that. So if an individual show by their behavior that they wish to engage in certain forms of sexual contact, and if the treatment team deems that this contact can improve quality of life of the individual, then third-party consent should be sought. So this is where the parent or the service providers can say, you know what, he can't give consent, but we can do it for him. Okay? We're giving consent for certain things. So remember we talked about programming where we're trying to control behaviors? Yes, we're trying to control, but we're also allowing for sexual expression that's safe and that's consensual. All right. I was told to end about 1:45, so we have lots of time for questions. I think we've had one question come on internet, right?
Yeah.
Earlier. And first off, is there any questions with you guys before we open it up to anybody and everybody? Well, actually, I'm not finished, but I have some concluding statements. But maybe I'll finish this part, and then we'll go into the questions. So basically, all I'm saying is individuals with FASD have a right to sexual expression. And because historically they've been denied does not mean we need to stop. And we've got lots of barriers, whether it's individual, personal, attitudinal, or structural barriers that really stop them from experiencing sexual expression. So to address the development of healthy sexuality for individuals with FASD, the issues must be normalized, not get ignored, which means involving parents, staff, and professionals. We can make a difference. And then I've got just some ways of incorporating sexuality into everyday practice, but I'm not going to go through them. So I've got here, timing is everything. Sure, you come first. You always come first. That's why I never come at all, the chicken and the egg. And you need to worry about timing when it comes for FASD. So questions and comments? No questions?
The one that came in
Okay.
earlier, you talked about it a little bit, and they were wondering if people with FASD are sexually active at any earlier age or have heightened sexual interests.
Okay. First off, what the literature shows is they appear to have heightened sexual interest, but actually it's probably the same as your able-bodied child or adolescent. The difference is the lack of self-controlling and self-limiting. So it looks like they have they're being more promiscuous, they're being more touchy, they're more all that. But in reality, it's just they're not self-limiting, and you're seeing some behaviors that the average child will not display. Like, for example, masturbation. Most kids masturbate, and you see it when they're 1, 2, 3, but suddenly it disappears, and all parents are going, "Phew, that stopped, thank God." But in actual fact, they know that it's something they should be doing in the privacy of their room, so now they're hiding it, so we don't see it. Individuals with FASD, they're not self-limiting, so you're seeing it. So I wouldn't say that they're heightened sexual or higher level. It's just the same, but you're seeing it more. The first part of that question was?
Are they actually sexually active at any earlier age?
Again, it may seem like it, but probably not. They might have the same curiosities and drives, but they don't limit themselves. So you're seeing some behaviors that you might not see in other children. So, and in terms of being more sexually active, they might try to model certain behaviors, but not any real difference between them and other population groups. Yep, Amberly?
With giving consent, at younger ages, let's say they were unable to give consent, is there, like as they get older, is there an ability for them to start to be able to give consent in some areas? Or?
Good point. That's actually a great, which I didn't talk about, sorry. But no, it's a great point because consensual ability, let's imagine you have somebody, whether it's a child or an adolescent or an adult, who doesn't have the capacity to give consent. But you decide to approach it from a situational approach. So you are giving third-party consent, saying that, okay, they're allowed to do this. And you know what? You're seeing a lot of improvement. You're seeing a lot of understanding and development of, sexual knowledge and all of that. So you're seeing a change. So suddenly, the situational consent becomes broader. So now you're adding a little more activity to the thing that you see that it's safe, and then maybe more. So basically, as they develop their skill base, you can change your level of consent. So it's not like once you've said it, you said it. You sort of look at if there is a development, you sort of move it along sort of thing. Does that answer your question? Okay, good. Any other questions from any sites?
I'm kind of tempted to weigh in on this.
Go ahead.
Consent thing that
Okay.
you're saying, because I agree with you, but there's a but.
Of course there's a but.
And here it is. You talk about them developing more understanding, and probably with some cognitive disabilities, that's very much the case. I tend to think, and I don't know this for sure, but with FASD, a lot of times they can talk the talk, they cannot walk it. And so they might get, with repeated practice in a group home setting or whatever, with repeated practice as to what this is appropriate, this we want to avoid, this is okay, this is not. They get, You know, with repetition, they do tend to get it.
Yeah, they're forming habits.
But they're habit forming. They're not necessarily developing understanding.
Mm-hmm.
And there you have, you know, you can't really tell. How much of this do they really understand for the purpose of forming, giving consent? How much of this is just habits that you have firmly entrenched in their lives? And really, I kind of think that they maybe don't really need to understand it if the habit is firmly entrenched in them. And so,
excellent
you
point.
probably base consent even on that.
Sure, and
you don't really know what's going on in that with the wheels anyway.
I look at myself, brushing my teeth, totally away from sex, right? But same thing. But you know, I think for me, no matter how tired I am at night, if I go to bed and suddenly go, oh, I didn't brush my teeth, I can't sleep. I have to get up, brush my teeth, and go to sleep. No matter what, I just can't go to sleep. I'm trying to get the same habit pattern in my kids. Forget about understanding about bugs and cavities and all that. I just want to get them into a habit pattern of that. In the same sense, if someone with FASD, yes, you're not sure about the learning. You're not sure if they're going to retrieve it at the right situation, in the right time, in the right context. However, what you are going to get is you're going to teach them that anytime a man puts his penis in your vagina, the only time it's going to be allowed if it's wearing a condom.
Exactly.
Right.
You have to make it so concrete.
Exactly.
And, you know, I noticed you used the word redundant in there somewhere, and I can't remember what context, but basically my motto has been from Tiny, consistency to the point of boring. Yeah, that's what they need. They need it to be consistent all the time.
Yep.
They need to know what to expect. And once you can ingrain that, but that's the big thing is, and I think the whole sexual, it's with anything. They need the education has to be, you repeat the same simple concept so many times that they could repeat it in their sleep.
Now, one thing, it's important to understand when we're talking about consistency, we're talking about environmental, contextual, and all of those. When we talk about education, that's one of the times where you give this consistent message, but in different delivery manners. So if you tell them the same thing over and over again, it's not going to work.
Right.
So now you tell them, you show them, you have them show you, you ask them how they're going to do it. So in a whole bunch of different ways, you're going to give the same message and redundancy, but in different modes. Okay? So if you're traveling to a place, you're not only going to take the car, you're going to take the LRT, you're going to take the bus, you're going to take the train, the plane, the whatever. All the different ways to get to the same point. Okay? Any questions else? Boy, you guys are boring out in the 68's things. They're afraid of asking questions about sex. Okay?
Thank you very much. Really appreciate your presentation today, Dr. Esmail. It was fantastic. Very informative, and it outlines the importance of safety issues, and I think it opens up a more positive perspective also, and to remind us of sort of supporting our families to work with sexuality in a positive way. A couple of notes for folks. Evaluations will be mailed to participants within the next 2 business days, so be sure to sign your attendance sheets. And your feedback on this session, as well as ideas for future sessions, is really welcomed. The next session is scheduled in 2 days, March 19th, from 1 to 3, with Brenda M. Knight on grief and loss, strategy support for clients. And now I just would like everybody to thank Dr. Esmail very much.